All right, welcome to the arterial lines presentation. So the first screen here, hopefully you guys have seen art lines or seen people draw off art lines over at the hospitals. So some hospitals will allow you to draw off A lines or insert A lines. Other hospitals will not. So that's something you got to be aware of. Some hospitals, like I said, RTs will manage arterial lines. Some of them, it's the nursing responsibility only. So it's something you have to be aware of. Now, I have this picture here on your bottom right-hand corner of the blood splatter on the wall. So there's a quick story behind that one. So when I was a new grad at night shift, I was drawing it off of an A line, and I was trying to expel the air bubble, and sure enough, the cap came off and squirted it on the wall there. So I felt really obviously embarrassed about that whole situation. But so be careful when you're trying to expel those air bubbles, otherwise you might end up with something like that and a lot of embarrassment. So just have fun. But not too much fun. Arterial lines are a great asset, especially when we're looking at blood pressure issues, but also if we have to draw frequent blood gases. So that's what we'll start to talk here. So arterial pressure monitoring, it's similar to an IV, but instead of the catheter being in a vein, it has to be into an artery, as well as this one can read pressures. So you can back pressure one that's in a vein, right? A central venous pressure is a catheter that's back pressuring in a vein, hopefully in the superior vena cava there. But indications for arterial line monitoring, frequent blood gases. So this is usually happens with your more of your ARDS type patients, but with your ARDS patients, usually their hemodynamics are poor as well. Let's say it's sepsis, right? So the massive vasodilation, they're going to have an issue with low pressure, so that's going to be an indication that they might need pressure medicines as well as frequent blood gases. So that's a great indication for an ABG on someone like that. So frequent ABGs, severe hypertension, because with severe hyper or hypotension, we're going to have to give them medicine that affects their blood pressure, and we got to keep a close eye on what's going on with their blood pressure. Instead of every 15 minutes, we need to sort of see what's going on continuously to see if the medicine's working. Should we go up? Should we go down? Right. So if they have a very volatile blood pressure, that's a good indication for an arterial line. Respiratory failure can be an indication. So if someone's on mechanical ventilation, they might say that they're go ahead to indicated to put an arterial line. But like I said here, the most common indication for an arterial line is going to be blood pressure monitoring, right? Especially if their blood pressure is high or low, that's going to be your big thing. Usually the people that have very labile or abnormal blood pressures might have some respiratory issues as well, because the heart and lungs sort of work together there. If you haven't gotten that by now in the program, hopefully you will. But yeah, absolutely the most common indication is going to be blood pressure monitoring. Sites for A-lines, pretty similar to arterial blood gases. Radial is going to be your most desired site. In theory, you could do ulnar, however, I would not consider that a primary site. Brachial can be a site, but remember with brachial, they have to keep their arm straight. Good luck on that one. How many people have you seen with IVs that keep bending at the elbow and they have an antecubital in, and yeah, things don't go well there. Axillary, in theory, could be a site. I've seen A-lines placed in all different types of places. Femoral is actually a more common place, so radial, brachial, and femoral will be your most common one, just like arterial blood gases. Femorals, you got to be very careful with, because now the patient can't bend at their waist or at the hip. So that means if they're in a bed, that the bed has to be flat at all times. It doesn't mean their head can't be elevated. You'd have to move the whole bed so they're elevated, so it looks like they're about to slide off. But you cannot bend at the waist if they have a femoral line. So just be cognizant of it. Radial line is obviously going to be most preferred. However, if the patient is on a massive amount of pressors or their blood pressure is super low, they may not be able to get a radial line, so they might have to go for a femoral. So the femoral can be tricky, of course. It's a deeper stick. It's a bigger vessel, of course. It's like the size of your thumb. But you also have other issues there that we'll get into the femoral. So here's a picture of a femoral line in this baby, and you can see issues with toileting, issues with keeping the site clean. You may not see if the cannulation comes out or if there's a bleed. It may be a little while before you're able to see it. So femoral lines can be tricky. You just cannot bend at the waist if you have a femoral line in place, right? So this is what you're looking at here. There's a lot of musculature that goes on here. It's a lot deeper than the radial site. So here you have not only nerves, but muscle, and you even have the great sap. Like, you have a lot of other stuff going on here. So the femoral is not a primary site, just like regular ABGs. If you have to get a site and they're massively vasoconstricted or hypovolemic, then the femoral will work, but it is not your first choice. Your first choice would be the radial and or brachial. Brachial would be obviously your second choice, just like blood gases. Insertion techniques, there's a couple of different techniques that are out there, so just be aware of whichever one your hospital desires to use. So you may be inserting arterial lines, depends which hospital you work at. Hopefully all hospitals down the road have good, well-trained RTs that are performing this procedure. So some of them use the needle to penetrate the artery, sort of like running a blood gas, and then you're going to use a guide wire through the needle into the artery. Then you're going to take the needle out, leave the guide wire in, advance the catheter over the guide wire. So it's sort of like using a bougie for intubation, right? You intubate with the bougie, and then you slide the ET tube over, you take the bougie out. Same thing here, right? You use that guide wire to slide the catheter in, and then remove the guide wire, and then the catheter is either sutured, or there's even a dressing that they can place on the wrist, and it snaps into place. It has this little flange here, and you sort of see, I'll use red for this, you sort of see this flange on the bottom there, and that's what you're looking at there. Is you can just suture it into place or secure it. So this is what you're ultimately doing with the catheter. You're trying to get it to float in the artery. So this isn't as easy as a blood gas. In fact, this can take a little bit more time. So if you're like, well, they're an easy stick, why aren't they easy to get an A line in? Well, first of all, it sounds like you haven't put it in a lot of A-lines, because you have to float that catheter. It has to be sort of centered in there. If that catheter is too deep or too shallow, then you're going to have an issue with the catheter not flowing, or the blood not flowing, or reading the pressures appropriately. So there's a little bit more fine-tuned detail here. So the blood pressure can be taken, blood pressure and samples can be taken through this catheter. But you gotta float that catheter. So if the patient bends their wrist, so it can be very positional. So if the wrist is bent, flexed or extended too much, either way can also affect the readings. It might even also affect the ability to draw blood as well. So we'll see this for patients that have A-lines in for a longer period of time, and hopefully they're not in for too long, but if they're in for a longer period of time, they might have to either switch a location, so take it all together, switch location, and or altogether just go off of no A-line, because it can be very positional, especially the longer it's in place. Alright, so I expect you to watch these videos. So they're good ways of looking at the A-line procedure. They're a little dry, but that's what you're looking at here. So you see that they use these little wrist boards, or positioning the wrist as much as they can to get optimal positioning, a superior positioning, or I should say a more surface approach with the radial artery. So the more we can get that radial artery to go to the surface with positioning, sort of like the head tilt chin lift and or the jaw thrust, right? You're positioning or aligning the TPO for intubation. You're allowing that positioning to optimize the insertion of the ET tube. Well, same thing here. You're allowing this positioning to optimize floating that catheter, and that's going to be the hard part, is floating the catheter. So it's not necessarily getting the flash and getting the blood, it'd be floating that catheter with the A-line insertion. So big complications with insertion. Obviously, hematoma is going to be one of your primary ones. Compartment syndrome, especially in arterial spasm. These are just sort of ginormous complications just from the insertion part. Infection could also be part of this if they didn't use proper infection, or if you didn't use proper infection prevention mechanisms, if you didn't use the proper protocol. It'd be a huge issue, right? Because now you're putting an indwelling catheter into someone's artery. So this is a very serious thing to look at. And so there are risks versus benefits just with any other procedure, right? So that's something to be aware of. All right, positioning of the monitoring. So the pressure bag up here has to be around 300 millimeters of mercury. So it has to be higher than the patient's blood pressure ultimately, right? So that's hopefully 300 is higher than your patient's blood pressure, unless you have a giraffe. They have super high blood pressure. But you want to keep that pressure higher than the patient's blood pressure. So that way blood doesn't backflow, right? You need that pressure higher. So that's that pressure bag hanging off the IV pole there. The pressure transducer is going to read the pressure of the patient's arteries as long as it's positioned appropriately. And then it's going to give us a waveform. And waveforms we're going to talk about in a second with being over-dampened or under-dampened. They can tell us a lot of information about what's going on. And of course, the saline-filled compressible tubing, so it's pressurized, it's pressure tubing, right? So it's not going to be very compliant, which is good. We want to read accurate pressures. Notice the level of the transducer is even with the level of this patient's heart. The fourth intercostal space mid-axillary, right? So that's even with the level of the heart. If the pressure transducer is too high or too low, that's going to affect the reading that we're getting from the patient. So we need to make sure it's level with their heart, with their fourth intercostal space. So this means, let's say their head of bed's at 30 degrees, and so their chest wall and their head are up, and we didn't move the transducer, then that's going to alter our blood pressure readings and therefore alter the way that we treat that patient, especially with blood pressure medicines and things like that. Very, very bad. And let's say we have this patient, they're at 30 degrees, the head of bed's at 30 degrees, which most ICU patients are, and we lay them flat to take them to CT scan or IR or one of those places in the hospital we have to take them to, and we don't re-zero the line when they're laying flat, then we're also going to have abnormal blood pressure readings, and we might actually think their blood pressure is good, and it's not, because we did not make sure they were lined up. We did not make sure that the transducer and their heart are level with each other. So that's something important that we'll have to do. So usually we re-zero the A lines when we're leaving the ICU room to take this person on a transport to the OR, to the IR, to CAT scan or MR, you name it. All right, drawing from an arterial line. Usually we have this three-way stopcock system. You turn it, so you put the syringe, you clean off the side that you're going to put the syringe on, you turn it to one side with the syringe, right? And then you draw a waist in theory. If it doesn't have we call them a vamp. Some of the A-lines out there have a automatic waist built in. You click it and you pull back and it draws a waist, and that's just mostly that saline and all the other stuff that's in the line. You don't want to get a blood gas off of that, right? Because it's just diluted blood. It's not going to be accurate. So you're going to pull back a waist, and then you're going to get your sample, and then you're going to put that waist back in if you have one of those inline systems. Now, if you don't have an inline system and this is an adult, you would in theory throw away that waste, because putting the blood back in or putting that mix back in could actually cause more harm. So neonates and pediatrics, of course, we're going to give them back the waste. That's a whole separate thing. Don't worry about that right now. But once you get your blood gas sample, you're going to flush the saline or flush whatever's in the bag back through the line. So there's this little tab, and you'll see it over here on the transducer. You'll see this little tab over here, and you just sort of pull that tab, and it allows from the solution from the pressure bag to be flushed through there. So any blood that's in the line, therefore, goes back into the patient. So you always want to make sure the blood goes back in complete, clean to site. Then I actually always said it out loud. I know it's nerdy, but it worked, and I never had an issue with a blood clot in one of my A lines because I always said, hey, clean to site. And I would say it out loud. Even if no one else was in the room besides me and the patient, I would say clean to site. That was my self-check of making sure that I flushed all the blood back into the patient that was in the line itself. So it's a good practice. I highly recommend it because, I mean, I didn't have any issues with doing that. The setup here, we already talked a little bit about this, that pressure transducer. On the left, you see the IV pull. On the right, you sort of see where you sort of want the line placed. So make sure the transducer is placed appropriately. So usually there's a transducer holder somewhere on an IV pull or something like that. And you need to make sure it's leveled correctly to where the patient's heart is, right? Just like aligning the TPO for intubation, this has got to be aligned in order to give you an accurate value of hemodynamic status, right? So it should be in the fourth intercostal space, mid-axillary. Notice that's the second time I've said that, so it sounds like that's an important thing to remember. If it's too high or too low, it could either overestimate or underestimate the amount of blood pressure. So we might actually think they're hypertensive or hypotensive, and then we might be treating them with blood pressure medicines that they don't actually need and could actually cause harm to the patient. Here's the good thing. If someone has an arterial line in place, almost every facility that I'm aware of also looks at non-invasive blood pressures too. So we're going to compare arterial line pressure with non-invasive pressures as well, just to make sure something like this isn't going on. So it's our fail-safe. The fail-safe, it would be a manual blood pressure cuff, right? Or one that's run by the monitor to sort of verify that the arterial line and the non-invasive are set up appropriately. So pressure waveforms, so we're going to talk a little bit about the waveforms here, and you do need to look at these. I will test you on them. You should have a clear upstroke on the left and dichrotic notch drop on the right. The dichrotic notch here is marked out in these pictures. The dichrotic notch represents the closure of the aortic valve. The aortic valve. So that's the closure of the aortic semilunar valve, right? So blood flows through, and then once the stroke volume or once the squeeze of the heart is done, that one-way valve of the aortic valve closes. And that's where you see that notch, is it closes and back pressures the aorta, which then will make sure that blood that's in the aorta distributes throughout the rest of the arterial system to the rest of the body. So if someone has an aortic prolapse or an aortic issue, let's say you're in a cardiac ICU and the aortic valve has a leak, right? The aortic valve has some damage, then you might not see a dichrotic notch. And so that's a sign that there could be something going wrong there. So be very cognizant of that's what it is looking at. And if your person has an aortic issue, an aortic semilunar valve issue, you may not see that notch. And that's just something that could be anatomically going on with them, and then you just know that that's going to be their waveform until that's fixed. Normals. Normal, of course, should be roughly around 120/80 for an adult. If you're hypertensive, we're looking at anything over 160/190. So systolically 160, diastolically over 90 millimeters of mercury. There should be millimeters of mercury after those. Hypotensive, anything less than 90 systolic or less than 60 diastolic. Now, is it possible someone's systolic could be 120 and their diastolic could be 100? Absolutely. And so that would be a form of hypertension. So you're going to have to look at both of those numbers. Now, understand these numbers can be a sign of cardiac function or low vascular volume as well. They could have a slow bleed. They could be dilating like they're going into sepsis, things like that. So we need to be very aware of these things. Sepsis is another great indication for an arterial line, right? Massive vessel issues, massive hemodynamic compromise. So we need to pay attention to these numbers because it could be a sign of poor cardiac function. Why does that matter to you? Well, hey, the heart, it's not the lungs, right? Well, you can have as much oxygen as you want getting into their pulmonary capillaries, but their pulmonary capillaries don't have the push to send it to the rest of their body. Then they're not going to oxygenate their organs, and they're going to go into what's called multi-organ system failure or multi-organ system dysfunction, right? So this is where you need to pay attention to blood pressure as an RT. That's a huge thing. Not only that, but if they're on positive pressure ventilation, blood pressure and hemodynamics can be a big side effect of poor hemodynamics, can be a big side effect of positive pressure ventilation. So this is something you need to be aware of. Before you go touching the mean airway pressure or the vent settings to increase tidal volume or to increase PEEP or to increase any of those settings, and they'll have low blood pressure to begin with, you better know what you're doing. And so this is something that you need to pay attention to. So I'll get off my high horse there. All right, troubleshooting arterial lines. This can be a little stressful, as you can see Beaker there. You have a pressure reading, but you're unable to draw blood. What do? Your dicrotic notch is dampened. Well, what does dampened mean? We'll talk about that here in a second. Pressure readings aren't matching with the blood pressure cuff. So who's wrong? The blood pressure cuff or the art line, right? Who's wrong? So how do you know, right? If you completely lose a trace altogether, what could that mean? What do, right? So this can be things that you'll have to look at. So if you have a poor pressure reading, sometimes it's a patient's in pain or they're in an artery spasm at this point. So if there's nerves, they're in pain, there's anxiety, there's something like that going on. So you might lose a pressure reading or have very poor pressure readings. This could also be a sign that, let's say they went up on their vasopressors. Let's say they went up on norepinephrine or vasopressin. They went up on a medicine that constricts blood vessels. Well, then you're going to have spasm. You're going to have the narrowing of those arteries, and that catheter may not, that indwelling arterial catheter may not be able to pick up that line. The patient's cold. Hypothermic patient. Of course, what happens to your blood vessels? Why do your fingers and toes turn blue when it's cold outside? Right? If you're not wearing the appropriate gloves and socks, right? So you're going to have vasoconstriction, right? And that vasoconstriction is going to reduce blood flow, right? So if they're cold, then obviously you're going to have a poor pressure reading. Poor perfusion, of course, right? Because you don't have enough pressure to keep that sort of vessel CPAP to send it to and keep that arterial catheter getting input. Maybe it's time to move the site too. We usually have to move them if we still think they need pressure monitoring. Then we'll have to move the site from the right radial to the left or vice versa. So that's something that we'll have to look at risk versus benefits, right? If the patient starts to develop signs of an infection, increased white blood cells, fever of unknown origin, so on and so forth, we might pull all the lines and send them for culture, right? We might pull the central line, we might pull the art line, we might pull all those and send them for culture. Well, we pull those lines, do we risk the chance of another infection or another insult by putting in another arterial line? Do we still need it? Are they still getting pressors? Are we still getting frequent blood gases? So those are all things we might look at where they might take out the A line and just leave it out, right? If the pressure transducer is leaking, we'll have a false low reading, right? Because we have a leak in the system, so pressure in the system will be lost. So this will decrease the blood pressure reading. So we might think the patient is hypotensive, and we might be giving them fluids or medicine to increase their blood pressure, and that would be inappropriate, right? If the pressure transducer is too high, let's say it's above the level of the heart, let's say it's at the level of the head instead of the heart for some reason. So let's say we laid the patient down. So they went from a 30-degree angle in sort of a semi-Fowler's to a complete flat in supine. So now the transducer is higher than their heart, and so that can increase the reading. So we might think that this patient is now hypertensive, and let's give them some medicine or let's do a procedure that actually decreases their blood pressure. Not a good idea, because now you made them hypotensive realistically. So this is also where I reiterate why we check a manual pressure. So when something looks off, hey, let's run a manual cuff. See what it is, compare the two. Does that verify what we're seeing? If the blood pressure transducer of the A line is too low, then we'll have a false increase reading. So if it's below the level of the heart, so let's say the patient is in a flat supine position, and then we raise the head of the bed up to 30 degrees, well, that means the transducer is lower than the level of the heart now. So that means that we might think that the patient is actually running a high blood pressure, and we might actually be given medicine to decrease it as well. So that's something that we have to look at. So if the blood pressure is too low, we'll have a false high reading. If it's too high, we'll have a false low reading. So dichrotic notches, so this is something that we'll talk about here. If it's dampened, and I have examples on the next slide, the following slides as well, so be prepared to evaluate those on the test. Dampened dichrotic notch means usually you don't see it at all. You don't see that closure of the aortic valve. Most of the time, this could be just like a little air bubble in the transducer. Hopefully, it's something simple like that. Compared to blood pressure readings, are they matching up? So this is what I was talking about before. Run a manual, right? You see something weird on the arterial line, run a manual, right? Compare the two. Is this an accurate number that we're seeing? Before we start pushing drugs or fluids or anything like that, before we start treating this, let's just verify that it's real first. Right? So what about drawing from a site that can't draw? So you go to draw an arterial line sample and you can't draw, you can't pull back, right? So this might be a positioning thing, just like the head tilt chin lift or lining the TPO for intubation. You just need to make sure the artery is sort of aligned with the catheter, because if the catheter is against the wall of the vessel, you may not have the ability to draw blood back from it. So this is just repositioning the wrist, right? Or if you try repositioning the wrist and they're in optimal position and it still doesn't draw, well, this could be spasm. Did they recently go up on pressors? Did they give more vasopressin? Did they give more norepinephrine? Is this patient in pain and causing vasoconstriction, right? Things like this could be all factoring into why you cannot draw that sample. So it's just something for you to evaluate and use your professional expertise in now that you know. Also, if the patient's too hypotensive, their systolic blood pressure drops below 50 or 60, the dichrotic notch may no longer be visible. So this could be a sign. If you do not see a dichrotic notch and you see hypotension, A, run a manual blood pressure, B, check a pulse. C, this is something that you want to verify that this person could easily be going into cardiac failure and you're catching it early. It sounds like if it's gone down to 50 or 60, then obviously you are in cardiac failure at that point, but you might catch it before their heart completely stops, which is the sooner you get it, the better. Yeah, the sooner you see that, the better. So that way you can work the patient before the heart completely decides to give up the ghost. Check for kinks or clots, especially over-distended tubing, especially if you get caught in the bed rail. I've seen that a bunch of times. Low pressure in the flush bag. This means you just need to pump up the pressure bag a little bit, or the bag needs to be changed out. This type of tracing will change the systolic actual pressure reading. So let's talk about that here. So pressure, if the pressure reading is not matching, is the location or the size of the blood pressure cuff in the right place. So let's say you run a manual cuff and it's different than what your arterial line is. So first thing, just make sure, right? These are the simple steps. Just make sure, look at the cuff. Is their cuff, the manual blood pressure cuff, tiny compared to their arm? Is it ginormous compared to the arm, right? If you have great grandma that's 4'8" and she's wearing a normal adult cuff that is too big for her body size, then it's going to read her as being hypotensive on the manual cuff because the cuff size is too big for her. So make sure you got the right size cuff on these patients. If it's too small and you got this ginormous 6'5" individual, then you're going to have an overestimation of manual blood pressure on these patients. So Just like ET tube sizes, you need to make sure that the manual cuff is also the right size for the right patient. Obviously, this gets very important when we look at neo and pediatrics as well, but in adults, that can happen from time to time. Not as common, but from time to time. Is the transducer in the right place, right? Before you start changing things and throwing drugs and fluids at patients, just make sure the transducer is in the right placement, right? Simple steps that you can do that will cost almost no time at all. Too high, too low, we already talked about what that means. If you completely lose a trace, reposition the arm, check the dressing. Is the tube kinked? Is it still in place? In other words, did they pull their own arterial line out? It can happen. So over dampening and under dampening. So this is where you're looking at the waveform, and if it's over dampened, that means that your diastolic or systolic pressures can be off from what they truly are. So you're not going to see a good downstroke of the waveform. It's going to be looking like a hill versus that sort of sharp mountain type look. So it's going to look like a grassy hill versus a sharp mountain look, that classic sharp rock cliff with that dichrotic notch. So you're not going to see that dichrotic notch. So you're just going to see that slow, gradual downstroke. So that's an over dampen. So that means it will underestimate systolic pressure. So in other words, their systolic pressure will actually be higher than what it's reading there, and their diastolic pressure will actually be lower than what it's reading there. So this means there could be a leak in the airline, so like a stopcock could be open, there could be air bubbles kinked in the bed rails of the bed, there could be blood clots if someone didn't clean it to sight when they last drew some blood off of it. They could be in pain, arterial spasm, right? They could have gone up on their pressors and now vasoconstricted in that area. The tubing could be narrowing for some reason or another, like I said, being squeezed, especially in a bed rail is a very common thing. So this is what it looks like when it's over dampened. So on the left you see normal with the dichrotic notch, looks like a mountain with a sharp cliff there. That's what you should see. Remember, the dichrotic notch represents the closure of the aortic semilunar valve. Over dampened here, remember, it underestimates systolic and overestimates diastolic. So you see how it just looks like a little hill instead of a nice mountain waveform? That's over dampened. That's usually a loss of pressure or kink or something like that. Something that's sort of stopping that blood flow from getting good, accurate pressure readings. Under dampened, this means you have a false high systolic or a false low diastolic. So this is where you have stiff tubing that's stiffer than what it should be for this job. The big one that you're going to see here is either the hypothermia, where they have that that constriction, that vasoconstriction, and or the tachycardia, or they went into a really bad cardiac dysrhythmia. So the tachycardia and cardiac dysrhythmia can easily cause an underdampen. So underdampen, I know it sounds counterintuitive, but it's going to be a large mountain range compared to your normal mountain range. You see how high those peaks are, right? So high vascular resistance, there's a high amount of back pressure. So it's nothing that's stopping it from getting to the transducer. It's just that high amount of back pressure. So this could be a resistance in the tubing, and it will overestimate blood pressure. So this is what we're looking at. They might have an underdampened waveform. Oh, their blood pressure looks fine, when realistically their blood pressure is actually low. So if you see an abnormal waveform, check a manual cuff and then try to troubleshoot the situation. If the manual cuff shows their blood pressure is low and their A-line shows an underdampened waveform, so that's overestimating their blood pressure, then you know to go by the cuff until you figure things out, right? As long as you verify the cuff is correct. Oh, I put some practice in here, right? Is this overdampened or underdampened, and what would cause it? I hope you know by now. Same thing here. Is this overdampened or underdampened, and what could cause it? All right, pulse pressure. This is a big thing. I love looking at pulse pressure, especially with A-lines, especially with mechanical ventilation patients. So you guys are getting there. The normal difference between systolic pressure and diastolic pressure is about 30 to 40 millimeters of mercury. So this looks at the stroke volume of the heart. So I can actually look at congestive heart failure patients and actually see how well their left ventricle is squeezing based upon their stroke volume, the difference between systolic and diastolic, right? It's called pulse pressure, but it relates to stroke volume or the squeeze of the heart, right? So decreasing the pulse pressure could be signs of a low stroke volume. So if I have a pulse pressure and I put this patient, let's say we have a pulse pressure of 40, and we intubate this patient and we put them on positive pressure ventilation, and now our pulse pressure is 25. What happened to their stroke volume? What happened to the amount of blood being squeezed with each beat? It went down, right? So we're causing some sort of restriction on blood from being squeezed out. In other words, we might have too much pressure on the thoracic cage, which is causing the squeeze of the vena cava. Remember, the most compliant vessel is your vena cava. Your heart's more of a muscle, right? So it's usually compression of the vena cava that reduces blood flow, that then reduces stroke volume, that then reduces cardiac output, which then causes their tachycardia. So if you see the pulse pressure narrowing, so you see a smaller and smaller pulse pressure, that's a sign of a decreased stroke volume or cardiac output. And usually what goes along with this, in order to compensate, your body will go into a more tachycardia. So if you start to see the heart rate, so you intubate a patient and you see the heart rate start to increase and their blood pressure, their pulse pressure start to narrow, right? So let's say instead of 40, we have 25, right? That's a sign that we might have too much thoracic pressure with the ventilator. We might have to titrate that in order to get optimal hemodynamics. So if you see an increasing of pulse pressure, this could be a sign of an increasing stroke volume. So this might be a sign the heart's actually getting better. All right, so let's say they're a CHF patient and we give them diuretics. We take off the pressure of their the amount of resistance their heart has to pump against, right? If we start to see their pulse pressure start to increase, let's say it went from 25 to 35, then we know that they have a better stroke volume, they have better perfusion, and as a result, their heart rate should start to slow down. So this means, especially with mechanical ventilation patients, I'm going to look at both the pulse pressure and the heart rate after and before I make any vent changes. Because if I increase PEEP, if I increase mean airway pressure, if I increase my tidal volume on this patient, then I could be causing a restriction on the vena cava and therefore decreasing stroke volume and decreasing hemodynamics. So this is very, very important. I cannot stress this enough. There's so many RTs that do not look at hemodynamics before and after their changes, and they can cause a lot of bad effects down the road. Because now, let's say we restrict, let's say their mean arterial pressure now is decreased, and that means their amount of oxygen delivery to their brain, to the heart, to their kidneys, to the rest of their organs is compromised, and it could be a big serious issue leading to multi-organ system failure because we were inappropriate with our vent settings, right? So this is something I want you all to pay attention to, right? Know and heed what the arterial line in the heart rate is telling you, right? So pulse pressure, difference between systolic and diastolic. Normal should be 30 to 40. You need to remember this. I will stress these. Mean arterial pressure, that's what I was just talking about here. This is the average amount of blood going through systemic circulation. So this is a good sign of perfusion. A lot of hospitals will, instead of targeting systolic, diastolic, they'll target a mean arterial pressure. They'll be like, hey, keep their MAP above 65, right? So they'll target a MAP. Or if they have an aortic aneurysm, they'll be like, hey, we're going to keep a lower MAP on this patient to avoid the aneurysm from getting too much pressure, right? So the calculation, and I would expect you guys to calculate this on this next exam, systolic plus diastolic times 2 over 3. So you spend twice as long, just anatomically, you spend twice as long in diastole as you do in systole. So that's why the equation is set up like this. Systolic plus diastolic times 2, because you spend twice as long in diastolic, over 3, because there's 3 variables in the numerator, therefore you have to divide it by 3. That will give you a mean arterial pressure. It's still going to be in millimeters of mercury. So a mean arterial pressure less than 60 torr, circulation to vital organs may be compromised. So treatment for this could be fluids, vasopressors, you name it. We have to look up blood if they're losing blood somehow. So an increased mean arterial pressure can actually be a sign of heart failure and or stroke. So the mean arterial pressure, because you spend twice as long diastole, that means that your heart's not squeezing as much, and so you're having more and more pressure build up during diastole. So it's a sign the heart is actually not squeezing well. So if you see mean arterial pressure increasing, and their pulse pressure decreasing, right? So you walk into a room, you see this patient on the ventilator, you see their heart rate's at 100. Right, and you see a pulse pressure of 40. And then you come back 2 hours later to check on this patient. You see the heart rate's 120, their pulse pressure is now 30, and their mean arterial pressure has actually gone up. That could be a sign this patient's going into heart failure. Can also be a sign of a stroke as well. So these are things that you need to pay attention to. If you're a critical care RT, you need to be paying attention to this. You cannot just look at the ventilator and call it good. You are part of the care team. This is important. Complications, ischemia, hemorrhage, infection, just like arterial blood gases. Big thing here, you're going to still use that 30 to 45 degree angle. You want to float that catheter. You have good flotation of the line in order to get good tracing. So it can be more difficult as far as placement than just doing a regular arterial blood gas. So that said, if we're going to put an A-line in a patient, we just intubate them instead of grabbing that initial gas. Ask them if they're going to put in an A-line, or if you're at a hospital where you're putting a line, do you guys want an A-line? Before you start stabbing away at their artery, maybe we just wait until we put a line in there, and then we can get that initial blood gas off of the line. So same type of problems there. Ischemia, obviously if a patient has ischemia, look for pale skin, that pallor distal to the insertion sites with their fingers, and everything looks sort of cold. That could be a sign there's an embolism or a thrombus or a spasm going on there. We might have to move the site, obviously. Hemorrhaging, the line becomes disconnected or a stopcock can be left open. This is a big needle or a big gauge catheter, and you can lose a half a liter per minute, which means the patient could completely bleed out in 5 to 7 minutes. It's a big deal, right? So that's something that you need to be cognizant of, especially if they have a femoral line in place, because how many people every time they go into the room are going to be looking at this patient's femoral location? Not many, and so it's not as widely checked upon as the radial site, or visible as the radial site, hopefully. So that's something that we have to be very cognizant of. Hemorrhaging is a big thing that we have to be careful of, especially if they have low platelets, for sure. Infection, the longer the line's in, the higher the chance for infection. That's why they'll pull it after usually less than a week or so, but each hospital has its own protocol for that. Be sure to have dressings and lines to limit the motion of the catheter. Usually they have those wrist boards. If the patient's running a fever, they might have to go ahead and pull all the invasive lines. Like I said, the central line as well as the arterial line, they might have to pull and culture those just to run them and see what was causing that infection. So something just to be aware of. Analyzers, you guys will go over that. Analyzer procedure, make sure, just like when you're running an arterial line, ensure the order is correct. Note the sample time, observe for error. So make sure when you're drawing the blood gas, just like a regular arterial line, you roll it in your hands. You don't shake it. It is not a shake weight. I've seen a student do that before when I was precepting them. We drew a blood gas and they decided to shake it, and they were told to shake it. I'm like, no, you were never told to shake it. I'm pretty sure it's a roll in the hands thing. Do not shake weight it, right? No shaking. So this mixes it with the heparin that's in there. Discard a few drops. That's to get any air bubbles or anything like that out of the sample. Remember, the air bubble artificially increased the PO2 and decreased the CO2, so that would alter the blood gas results. So that's why we discard that. Usually, as long as you get all the air bubble out, that's what we're looking for. Put the sample into the analyzer, confirm the readings. Do they make sense? Do you need to rerun the SANS electrode, right? Analyze our procedure. Be sure to apply standard precautions to ensure the machine's working in use. In other words, make sure everything's been calibrated and run. Usually we have known pH samples and known gases that we can run through the blood gas machines before we do an actual blood gas in there to know specifically are they on target. So I think one's at 6.38 and another one's like 7.84. Like, we have known pHs, and we will run it just to make sure that it's calibrated and it's running appropriately. So clots in the blood gas could easily cause any issue. That would be a sign you didn't mix it well enough. Bubbles obviously can alter the blood gas itself. So if there's an air bubble, your PO2 is going to increase, the CO2 is going to decrease. The pH will also be altered because the CO2 is going down, so therefore the pH would go more alkalotic because there's less carbon, there's less acid in there. Venous, of course, if you drew a venous blood gas and you told the machine, hey, it's an arterial blood gas, it's going to read off as well. If you took too long and it metabolized, you're going to have a high CO2, a low pH. If you had too much heparin in there or coagulation, it'll change it as well. So be sure that you notify the care team that, oh yeah, there was an air bubble because now their PO2 is reading 150, but their saturation is super poor, and so on and so forth. So that's something that you notify the physician. Right? There's air bubbles. That's not an accurate